Well then, hello, good morning, good afternoon, good evening, everybody. I would like to welcome all of our webinar participants to the Immunization for All Ages Driving Policy to Action webinar. This is a webinar designed and presented to you by the Immunization for All Ages Steering Committee and made possible with funding from Pfizer. If I could ask for the next slide, please. One more, thank you. So in this webinar, we will explore how we can work together to raise awareness around the Global Immunization Agenda and why we should be driving immunization for all ages policy as a health priority and action. My name is Justin Ortiz. I will be the moderator for this webinar. We have a number of distinguished speakers to discuss about how global strategies such as the WHO Decade of Healthy Aging and the WHO Immunization Agenda can be meaningfully implemented at a national level, and what role civil society can play in driving change through the three interconnected pillars of prevention, access, and equity. Next slide, please. The Immunization for All Ages Steering Committee represents a number of organizations. They include the Confederation of Meningitis Organizations, the World Federation of Public Health Associations, the International Pharmaceutical Federation, the International Federation on Aging, International Longevity Center, and Shot at Life campaign of the United Nations Foundation, as well as Pfizer. Next slide, please. This is our agenda for today. We have three main objectives for this webinar. They are to describe why and how to drive policy to action by intersecting global agendas of immunization and healthy aging. To position vaccination as the essential public health action to support the adequacy of health and social care systems which are threatened. And to translate lessons learned from the current pandemic as a response to barriers encountered in improving vaccination uptake rates, especially in vulnerable groups. Our panel of experts include Dr. Michael Moore. Dr. Moore is a past president of the World Federation of Public Health Associations and a distinguished fellow of the George Institute for Global Health. In session one, he will discuss the importance of evidence-based policymaking in public health. Next will be Dr. Jane Barrett. Jane is the Secretary General for the International Federation on Aging. She will discuss in session two the impact of public health messaging on the uptake of adult vaccinations. And finally, in session three, we will hear from David Sinclair. He is the Director of the International Longevity Center in the United Kingdom. He will discuss the economic effects of investment in public health and immunization. Michael, Jane, and David are all co-leads for this webinar. These sessions will then be followed by 30 minutes of discussion. Our webinar participants will have the opportunity to submit questions through a Q&A function in this webinar platform. I kindly ask that you direct your questions to all panelists. Event staff will organize these themes to make the Q&A more efficient, and I will moderate the Q&A session to align with our webinar goals. In keeping with these goals, we will not discuss specific vaccine products, but the larger themes of vaccine policy and public health action. Next slide, please. One more, please. All right, so I'm very pleased to introduce Dr. Michael Moore.
Thank you very much, Justin. I appreciate the introduction and very pleased to be here. I'd like to move to my first slide, please, and begin by challenging us in terms of public health. So the next slide, please. I don't appear to have the next slide. I wonder if we can manage to get the slides to come up. Thank you. So my first slide really ask that question about what happens when public health fails, and what could be more obvious at the moment with the current pandemic. And the interesting part is it's not just we see an overall failure, we also see successes. So some countries have managed to handle, for example, the COVID-19 much more successfully than others. And this has been really the story of public health. We look at measles outbreaks, and if we go to Romania and Italy, and more recently in Samoa, and in Samoa, the outbreak of measles brought about a huge series of deaths of very young children, and of course that was the case wherever we get these measles outbreaks. So what's happening is the real question, and what we're really dealing with, I think, is that prevention paradox. When prevention is very successful, nobody knows. When public health fails, then people become very, very aware of it. But there are some successes that really stand out, and seatbelts and the use of other techniques in terms of motor car morbidity and mortality, or sickness and death, is a really good example. And certainly in my own country, in Australia, we have the same rate of sickness and death associated with automobiles now as we had in the 1930s, despite the huge increase in population, the huge increase in kilometres driven, the number of cars, and so on. And the success story is not about one thing. It's about a whole series of things. And that's often the story, or normally the story, with public health. And it's a similar story with tobacco. Our regulations have been successful, not on their own, but when there's campaigns that are run with with regulation, and they work together. And so we had regulations that restricted where people could smoke. We had campaigns explaining how tobacco kills. We had packages that first of all started with small pictures demonstrating small word warnings until we now have plain packaging of tobacco. And it'll be very interesting to watch how the successes and failures in different countries with regard to e-cigarettes, that some countries have made these very, very widely available. Others have made them available on a very restrictive measure. So the success of preventive measures are very difficult to measure because of that particular paradox that I mentioned just a short while ago. Can I have the next slide, please? And so I think it's worth just stepping back and saying, well, when we're talking about public health, what are we talking about? And the World Federation of Public Health Associations has developed the Global Charter for Public Health, and it's built on these series of other charters and other systems, and certainly it should be read in conjunction with the UN Sustainable Development Goals. But the nub of it are these elements that you see in the middle of the diagram: protection, prevention, and health promotion. But they don't work on their own. They can only, those basic concepts can really only work when we have good governance, when we have accurate information, we have effective advocacy, and capacity building. And so when we're thinking about public health, it's really important to think about those three concepts of protection, prevention, and health promotion. And then how do we implement them becomes the, if you like, the enablers or the functions. And can I have the next slide, please? One of those areas was advocacy. And so this is my own great area of interest. But the most important part of advocacy is actually knowing what you want. And so today we're talking about policy to action. So you have to have the vision. You have to understand what it is that you're trying to convey. And in that way, we can ensure the most effective advocacy. And these advocacy steps that I show at this time are sequential steps with one exception, and that's step 7, being opportunistic. And clearly opportunistic is when you get a chance to intervene. And I'm going to now elaborate on each of these, and I'll do that really a couple at a time. So if I can have the next slide, please. The first one of those, as I say, is the developing a change vision. The change vision doesn't work unless it's based on sound evidence, and public health is really illustrative that evidence works. But it does a lot more than that. When you base your vision on sound evidence, then not only are you recognised for your honesty, but you improve the credibility. And the other element about the evidence is you limit the risk of damage, and that damage can be health damage, can be economic damage, it can be, and it can be regarding about litigation. And a really, really good example at the moment is the development of a vaccine for COVID-19. If we don't get a vaccine that's based on very sound evidence, then the risks of damage to health economics and litigation just multiply. And look, we have a really clear example from Wakefields' article in The Lancet with the association, the false association of the MMR and autism. And look, how many people have died because of that false association? How much suffering, how much disability, and how many reputations were destroyed over that particular example. There is one other element, though, that's really important when we talk about sound evidence. Keep in mind that sometimes the evidence changes. We get new evidence, and we have to also be flexible enough to go, actually, there is new evidence, and we are going to have to now say what we thought was the case now we have learned is not the case, and here's what we should do about it. Can I have the next slide, please? The next step is really interesting in terms of getting action, particularly from governments. If you don't have somebody who's in politics, and I spent 13 years in politics myself and was a Minister for Health, if there's not a sense of urgency, then you don't get the priority. So if government are going to prioritise something and you're trying to convey that an important issue, then you must make sure that there's a sense of urgency is created. Often in public health, the way to create that sense of urgency, in as far as it's possible in terms of public health, is actually to look at the impact on children in particular. Because guess what, the community and politicians are much more responsive to that. The next thing, though, I think is the important step is to make sure you're not trying to influence by yourself. We really know the impact of creating a guiding coalition, because a coordinated voice carries so much weight, and that's why it is that there's a series of groups involved here in this international federation. It's very difficult to do any of these without developing and maintaining influential relationships, and maybe we should be taking a page out of the book of the tobacco or the junk food industry, and we know that their lobbying impact in our governments is really quite strident. And a recent survey looked at the number of people who are involved from those industries who are actually paid lobbyists. And it's certainly a lot more than public health organisations can afford. But what we do have is credibility. And so contacting and being in touch with the Member of Parliament, being involved in the development of a political party's policies, these are all things that can help have serious influence. But you start with that simple call to your local Member of Parliament, your local councillor, your federal Member of Parliament, and perhaps you might not speak to them in the first place, but your chances are very high that when you've got a clear vision, you'll be able to talk at least to the appropriate advisor, and then build that. And when we say maintain influential relationships, we're not just talking about politicians and so on. We are also talking about appropriate people in the media and in other places, people of influence. Can I have the next slide, please? And of course, if you can't communicate that vision for buy-in, then you're probably not going to be successful. And here we use both the traditional media and leveraging on social media. And in fact, I would even go so far as to say flood social media. And we do that when we really start a movement going. Then how can you build beyond the guiding coalition becomes the question. I did mention being opportunistic before, and being opportunistic may just be the time you happen to, and we use the term the elevator pitch, but the time that you happen to get 30 seconds with a person of influence, media, politician. I know that there were times when I was in politics and I was watching my daughter playing soccer, and people would just raise a small issue with me. It happens at odd times, and you just have to be very clear in what you're doing. But you also have to be careful that you're not interfering with that person's time. And often a very brief pitch, and is there any chance that I could talk to one of your advisors about that? Now the next slide, please. So it's also worth understanding that we generate short-term wins, because it's a very common saying that politicians can only think of the next election. Actually, most of them think beyond that, but they have to get re-elected to deliver the broader vision. And therefore, if you can give short-term wins, which are often about output rather than about the outcome, and that distinction is important. Never letting up is a key element, and Professor Rob Moody often refers to the 3 Ps of persistence, persistence, and persistence. And then finally, what we have to do is make sure the change is incorporated into culture. So we see this with the anti-smoking campaigns. It's really, smoking cigarettes is really antisocial. And what a marked contrast that is, even from 25 years ago. And how do we apply that in immunisation? Should immunisation be compulsory, or should just the changes in culture, like smoking, be so embedded in the way we think that it would be completely unacceptable to not be immunising? Have the final slide, please. So our key considerations then are to think about prevention, equity and access. I mean, that's what we're really interested in doing as far as this goes. So the first thing we have to do is move immunisation policy to action, and we have to make it relevant for all stages of life, and then use these 3 things to drive those fundamentals, which are prevention, equity and access. Look, I really appreciate the time, and thank you, Justin.
Thank you very much, Dr. Moore. We sure appreciate your experience and your insights in the subject. I want to remind all of the participants in this webinar that we absolutely encourage questions. There's a Q&A function within the WebEx platform. Please submit your questions to all of the panelists, and we will organize them and ask them at the end of the webinar. Up next is Dr. Julie Barrett. As I mentioned previously, she will discuss the impact of public health messaging on the uptake of adult vaccinations. Thank you very much for joining us, Dr. Barrett.
Thank you very much, Justin. And can I have the next slide, please? And the next one. What is important to all of us, but most of all older people, is their ability to function and remain independent. You know, there's a real fear in all of us that, you know, our last days will be with dysfunction and the inability to look after ourselves. So these definitions from the WHO back in 2016 really emphasise that ageing is a process, and we all have a part to play in creating an environment that enables us to do what we have reason to value. As I mentioned, ageing starts at birth, and across the life course, Many people of all ages have the opportunity to access the most effective public health interventions of our time, second to only to safe and clean water, and that's vaccines. But despite the fact that older people are particularly susceptible to vaccine-preventable diseases and are overrepresented in morbidity and mortality rates globally, the long-term adverse impact on the functional ability of older adults has really largely been overlooked. IFAA believes that there's a general failure of health authorities to acknowledge and adequately fund the prevention and treatment of infectious diseases that cause severe and enduring social and economic consequences for not only the individual but the family and the broader community and society. Next, please. Driving policy to action in the areas of prevention, access and equity, each of these pillars are interconnected, requires a deep understanding of situational context. So some of my presentation today is really going to speak to the situational context at a country level. If vaccination uptake rates are the main indicator of national campaigns, then we have to say that they're mediocre at best. And while campaigns and campaign messages are only one part of the equation, and we could be talking about reimbursement and the difficulty for older people to be vaccinated, you know, the vaccinated gateways or the lack of awareness, we really do have to pay attention to what do these campaigns look like, where do the messages go, and how do the messages translate into action. Given the profound underuse of vaccination among the general public, but most importantly among those greatest at need, older people and those with underlying conditions, you know, the IFAA decided to dive deep into understanding, you know, vaccination campaigns and messages in 10 different countries. So this presentation actually starts talking about, you know, the policy of vaccination campaigns and how we can drive to action. So as I mentioned, this 10-country study analysed message content, structure and methods of dissemination of influenza vaccination campaign messages, but, you know, the findings are much broader than that. So the title of the study is Changing the Conversation on Adult Vaccination. It showed generally significant gaps and very worrying trends that we can take action about. There is an assumption that public health campaigns result in improved uptake rates, and this is just not the case if you look at country rates and what appears to be a relative lack of attention to communication to the at-risk populations. For example, many of you may not know that only about 2% of the population in China are vaccinated against influenza. So let me talk about some of the findings of this study. And first of all is the universality of messages. And as living in Canada, and we're moving into the flu season, you know, respiratory infectious diseases include influenza as well as pneumococcal pneumonia. But there is a universality of messages. So you could be guaranteed that in many of the 10 countries that we studied, you know, one standard message is, it's flu season, go and get your flu vaccine. Now, while some of you may think that that's a positive message and a snappy tagline, you know, many of us really want more information. And many of us actually think that we're healthy and we don't need any vaccination. So it's the disaggregation of a tagline that is actually really key. Also, you know, the universality or the sameness of messages suggests that everybody has the same level of literacy, health literacy, and we know that that's just not the case. You know, work by Sir Michael Marmot, you know, about, you know, the social determinants of health clearly states that health literacy, education, where we live, you know, the family that we're brought up in, but also culture plays a very big part in understanding public health messages, that Michael was talking about. A second finding was there was an entirely lack of quality and persuasiveness about the messages. Some messages address general inquiries rather than prioritising, the unique nuggets that a person with a chronic heart condition may really need to know. People with heart conditions, diabetes, lung conditions, those who have weakened immunity, immunocompromised, they actually need to know that they are at great risk of serious complications, which include death, but they also include such a significant decline in function that it may mean that they may not be able to live independently. And that's the single most important thing as we grow older. We want to have a life of independence and autonomy if we can, and we need to and want to live in an environment that enables us to do what we have to value. Some of the messages, and this is my third finding, some of the messages were incomplete, like taglines, which almost de-emphasise the serious nature and the protective impact of vaccination. So, flu season, go and get your flu vaccine, is a tagline that calls on us to do something, but there is no urgency about that. I don't know from that tagline that it is serious. I may be hospitalised. If I've got a heart condition, it may actually exacerbate that condition. I may die, but also I may not be able to go on those long, lovely walks that I often do. The fourth finding is tailored messages to an individual or group needs is critical and was largely ignored by campaign leads as they fail to make use of the interactive nature of public health campaigns. Most audiences passively receive information from a variety of channels, from videos, brochures, posters, press releases, but there's very little opportunity to ask questions. Now, we would hope that if you go to your doctor, if that's where you're vaccinated, or the pharmacist, you have that opportunity to ask the question. But that means that you've already made the decision to be vaccinated. And I think we need to actually step back and have that point of contact where we ask those questions. What vaccine? Why should I be? What month should I be having the vaccine? Does it protect my family if I have the vaccine? Keeping in mind we don't all have the same level of literacy when it comes to health decisions. Drawing from the findings across these 10 countries, we've actually been able to develop a conceptual framework with 7 key components that characterise effective communication campaigns and strategies. And this important conceptual framework enables us to then talk and speak and engage in policy discussions, not only at a governmental level, but also with our colleagues in patient organisations and seniors organisations who must be advocating on behalf of and with their constituents. Now, intelligence from this study provides a very important and very useful reference base to bring attention to not only the gaps, but some very good practices. And surprisingly, it may be to you, but Brazil, in terms of influenza vaccination, has very high uptake rates. And there are a number of different factors, but read our report, particularly on Brazil, to know that there is something called D-Day. And D-Day, and one particular year, 43 million people were vaccinated against influenza. So we have a lot to learn from other countries, but most importantly, we actually have to look within country, the situational context. So I challenge you to just look up your public health vaccination campaigns and see if you can pick good practices or whether attention needs to be given. Next slide, please. In the current climate of COVID, and Dr. Moore has already just touched on this, It is more important than ever to drive policy that protects older adults and those with underlying chronic conditions. We know in the discussions around the development and the clinical trials that many of the vaccines that are being developed do, and I could say for the very first time, and that's probably not the truth, but you know, what we're having is we've got clinical trials where we're targeting older people, not the 65 and over older people, but perhaps the 80 years and over older people. This is vitally important, not only in the development of effective vaccines, but also to encourage policymakers to go beyond what we're doing now in clinical trials for current and future vaccines specifically to the needs of older people. I do want to touch on pneumonia, and the reason that I want to touch on it is that there is a plethora of information activity, almost frenzied activity in some countries about the need to be vaccinated against influenza, and that's so the case. But we need to also at the same time be talking about pneumonia. Pneumonia has life-threatening consequences in many at-risk groups, including older people. With 75% of older people with chronic conditions, the risk that pneumonia and its serious complications will lead to diminished functional ability and even death is extremely high. You know, while there's been necessary focus for influenza vaccines, you know, the IFAA and many others are calling on a broader perspective, a broader call for action to use the existing vaccines that we have, which in large part are effective for the broader population and target groups of older people and chronic conditions. So we call for action to broaden the message so that people can not only be more educated around the need for vaccines, influenza, pneumococcal pneumonia, shingles, pertussis, Tdap, you know, but start becoming aware of the decisions that we can make. Thank you. Next slide. And in closing, I want to just think vertically. What I've been talking about in broad perspective is the situational context at a country level, because policy conversations happen at a number of different levels. They happen organisationally within IFAA, within the Diabetes Federation, within the World Federation of Public Health, you know, the International Federation of Pharmaceutical, you know, at a number of different levels. So patient, advocacy, government, you know. We also need to think of the information and the messages that we're sending to the WHO, the World Health Organization, with its 4 action areas for the decade: the way we think, feel and act about ageing and growing older, ageism, long-term care, primary integrated care, age-friendly cities and communities. These 4 action areas, through the lens of adult vaccination, give us very many points to launch conversations which are critical to the livelihoods and lives of older people and those with chronic conditions. The Decade of Healthy Ageing is also connected to the WHO Immunisation Strategy 2030. It's also connected to the United Nations Sustainable Development Goals. So wherever you are, you have a role and a responsibility to drive policy to action within the framework of improving uptake rates of adult vaccination and for those with chronic conditions. So thank you very much for enabling me to be part of this webinar, and I'll hand the floor over to Justin. Thank you, Justin.
Thank you very much. I always enjoy hearing you talk, and you know, the global perspective you bring is really, really helpful. I want to remind our participants, our attendees, that they are welcome to ask questions. I know I have several for Jane. I would ask you to submit them in the Q&A link through the WebEx system, and we will organize those and ask those in a couple sessions. But first, I would like to introduce the third and final speaker of this webinar. David Sinclair is the director of the International Longevity Center in the United Kingdom, and he will discuss the economic effects of investment in public health and immunization. Over to you, David.
Very much, Justin, Jane, Michael. Great to be here and joining you all. If we can move on to the next slide, please. And the next one. So I work for the International Longevity Centre in the UK. We're the specialist think tank on the impact of longevity on society. Essentially, we are, and perhaps let's move to the next slide. We're an organisation, we are one of 16 ILCs across the world. We were established in 1997, and we work to really try and provoke conversations, pioneer solutions for a society where everyone can thrive regardless of their age. And my boss, Baroness Sally Ringross, is our Chief Executive. Please, let's move to the next slide. So I suppose I want to make 3 points really in this presentation. The first one is, and it's an obvious one for most of us on the line, that the world is aging. We're very successfully improving life expectancy pretty much across the world, but actually we're not aging equally well, whether that be, and we're not aging to an equal extent. So not all of us are aging healthily and benefiting from all of the potential sort of improvements in health that we have seen. Second point is that aging is clearly often seen as a threat or cost. So the narrative around old age is that, you know, more older people is going to cost us more for pension, in terms of pensions, in terms of health, in terms of care. So the story is often very, very negative. And then thirdly, and I think this is core, is that actually there is a really strong positive message that there could be a very significant economic boom, a longevity dividend that comes from governments as a result of doing aging better. And actually it's already the case, as I'll highlight, that older people are contributing massively to the economy and society, but actually whether that be through working longer or spending more, volunteering, caring. But actually what we know is that this contribution could be much more significant if we invest in preventative health. And let's move on to the next slide. And then perhaps the next slide as well. So yes, we know we're living longer. We know that young people today are going to be, you know, potentially live very, very long lives, and this is and life expectancy is increasing significantly across the world. But actually, as I just touched on, we're not aging equally well. You know, even within Europe, you see a significant difference in life expectancy, and particularly healthy life expectancy across different countries and different bits of the world. So whilst we're living longer, we're not, you know, aging well to the same extent. Next slide. And this sort of leads to the sort of slightly negative story we sometimes see around aging, and this is a very common thing. It is the story, as I say, that, you know, aging could cost us lots of money. And this is a quote I found from a former US Secretary of Commerce, Pete Peterson, who talked about aging being a threat more grave and certain than chemical weapons, nuclear proliferation, or ethnic strife. There is a sense of negativity around aging, which I think we need to challenge, and I think where preventative health can challenge and help turn this story around. So moving on to the next slide. So the you know, this is the other side, I think, of this story, that whilst you know, the challenges of aging could be daunting, they are not insurmountable. And this is Professor David Bloom, and I remember him talking to me about sort of demography isn't destiny. You know, that actually, you know, there are ways that we can ensure that our sort of demographic future, our aging world, actually, you know, it is not perceived to be a negative. Let's move to the next slide. And to give just 3 examples, and I should say on Monday we're launching a new report which puts in some new figures across the G20 and the European Union about the extent to which older people across the world are contributing to the economy through work, through volunteering, and through caring. And the figures are very, very significant. So, and I will probably breach my own embargo here. But actually, for example, the report we are releasing on Monday will reveal that across the G20, about 1 in every $3 generated by workers is by workers over 50. So you are seeing already a very significant contribution of older workers, of older people to the economy through work, and this is only increasing. You know, it is worth reflecting that actually this is not the picture everywhere. So in some countries you see very, very low levels of employment of older people, but actually older people are already contributing a lot through work. So the next slide. What you also see, and again, our new analysis that we were publishing on Monday will highlight this, that over 50s are contributing a huge amount through care. And, you know, you see different figures, different levels of contributions here across the world, across the EU. But actually, it's very clear that older people are contributing significantly to the economy through informal contributions such as care and volunteering. The next slide. And then finally, what we also see is that sort of linked into the sort of work, you know, total earned income as a proportion of GDP is set to increase. This is from the UK, but you are seeing a growing proportion of income being generated by older people, of GDP being generated by older people. We're also seeing a growing proportion of older people, of consumption coming from older people. So older people spending is also generating significant economic growth. Next slide. And yet what we also know is ill health costs the economy. So our analysis as part of a program of work we did on prevention in an aging world last year showed that 27 million years in richer countries were lived with a disability due to largely preventable conditions, and that productivity loss, for example, and we've heard a bit about flu today, that the cost to economies of preventable diseases are huge. So again, in richer countries, £39 billion cost in terms of flu, for example. The next slide. And to add to that, what we also found that flu cost around 159 million working days in better off countries. So there is a massive, massive economic cost of not investing properly in prevention, and in particular in terms of tackling the challenges of preventable diseases, of vaccine preventable diseases. Next slide. So you know what I suppose we you know the final point, and so I suppose where I've got to is, yes, we're living longer. Yes, we're not equally we're not aging equally as well. So you know, some places we are benefiting more than other places in terms of how well we are aging and the extent to which we are aging healthily. But actually, I think what we find, and again, our report that we're launching on Monday will highlight this to a much greater extent, there is a very, very strong relationship between good health and economic contributions. So what we find, again, in the report that we're going to be releasing next week is that in countries where governments spend more money on preventative health, we see people working longer, we see people spending more, we see people caring more, we see people volunteering more. There is a very strong relationship between prevention and investment in health. And yet what you also see, this is influenza vaccination rates for 2019. You know, if you look at some countries like Estonia, down at one end, you see very, very low rates of uptake of certain vaccine-preventable diseases. Other places like Korea, the UK, New Zealand, Australia have much higher levels of uptake. But actually, even though, you know, if you look at this chart, what you see is that the WHO set a target about 10 years ago now for uptake of influenza vaccine amongst adults, amongst older people, and actually 10 years on, very, very few places have met that target. So there is still much, much more to do. Next slide. So what we do know, though, is that governments say that they are committed to preventing ill health. Where, you know, this time last year, over the last year or so, we've been going around talking to governments across the G20, saying, you know, tell me, tell us about your commitment to prevention, and you know, fairly, you know, universally, G20 governments, ministers all say that they believe in prevention. You know, all government white papers, government green papers, all talk about it. They all say we believe in it. They all actually also say they believe it works. And I think there is increasing and very strong evidence, and I'd say our work next week will strengthen this, that in the long term prevention is really cost effective. And that actually a failure to prevent ends up costing healthcare systems much more in the long run. And in fact, I think what you see with the current pandemic is that actually the cost of prevention, is much, a failure to invest in preventive health has very, very significant economic risks that go way beyond just the health costs. So clearly, I think the health and economic costs of failing to act are really substantial. Next slide. So why don't we do more? And this may be something we want to talk about. I think if you look across the world, there are a number of different sort of reasons and factors as to why we don't focus enough around why prevention, why adult vaccination, why vaccine preventable disease don't get the attention they should. One is that you see issues within some governments around the extent to which we are investing, to the extent to which budgets and funding mechanisms support preventative interventions, whether they be vaccinations or others. We've, I think, historically seen challenges around organizational leadership in different countries in terms of delivering a prevention agenda. I think, and Jane touched a bit on this, in fact touched a lot on this, the real failure for us to create clear, sustained messaging for non-health policy makers and stakeholders around the benefits of preventative health. We've also underestimated the importance of preventative health historically, particularly, as I say, in relation to the economic benefits. But this is even before, and this is where I think cost saving versus cost effectiveness is important. This is before we even consider actually the real social value of ensuring that older people are able not just to work longer, not just to spend more, but also be really active members of their community through volunteering, through caring. The economic value of older people to economies is huge, and often a sort of focus on cost saving doesn't recognize this value in terms of prevention. So finally, my final slide, I suppose, I just wanted to sort of say, well, what do we need to do now? So just moving to the next slide. So in terms of the next, so what do we need to do? I think the work we've been doing over the last year in terms of talking to G20 and EU governments, We argued that what we, after spending a year talking to them, there were three things that we really need to do. One was democratize access to preventative interventions, and what we mean by that is to ensure that people, no matter where you live, no matter what your ethnicity is, no matter whether you live in a rural or urban area, that you have access to preventative treatments. That, it shouldn't be the case that if you live in one place, one country or one region, you have access where in another bit of the world you don't. Secondly, I think we need to, and this builds again a bit on what Jane was saying, inspire and engage people, communities, professionals. Again, really, really pleased we are working with FIP here, the role of pharmacy, extraordinarily important. And I think the reason engagement activity, and then finally, I think we need to effectively use technology. What we're doing over the next year is, we said these are the things that need to be done. So over the next year, we're going to be working with governments and with others to try and identify not just the what, because as I say, ministers say that prevention matters. They say that investing in tackling vaccine preventable disease is important, but actually move on to more, how do we make this happen? So how do we democratize access? How do we best use technology, and how do we inspire and engage people? And I look forward to working with you all on that. So thank you very much. I will stop there.
Thank you very much, David. I really enjoyed hearing about your work, and thank you for sharing the fresh, off-the-presses data with us. We'll keep it to ourselves until it's public, I promise. We have reached the end of the three sessions. If I could get the next slide, please. I would like to introduce the next session, which is the Q&A. I want to inform all of the attendees that we still have opportunity to ask questions. If you go to the Q&A function in the WebEx, you can enter questions. Please direct them to all of the panelists. We are going to organize them and present them, as many of them as we can in the remaining time that we're given. As the moderator, I'm given a certain leeway, perhaps, to ask some of my own questions. The first one I want to ask of all three of our panelists, you three obviously are very knowledgeable about adult immunization, about advocacy, and driving policy to action. You represent three organizations, or sometimes even that, but I was particularly interested in the World Federation of Public Health Associations, International Federation on Aging, and the International Longevity Center. We received a clue about the work that those organizations do, and it sounds very critical and appropriate for this conversation. But I was wondering if maybe I could ask you to expound a little bit more about those organizations, what they do in general, but more specifically, the activities that those organizations are undertaking to advance adult immunization. And perhaps we could go in the order that you presented. Thank you.
And so the World Federation of Public Health Associations has over 100 public health associations worldwide in its membership. And so there's a flow that comes up from the members, and there's a flow that goes down to the membership. So in terms of your very specific question about how do we encourage adult vaccine, well, we do use webinars, we do use a run of techniques, and certainly in my role as chair of the Global Task Force for the World Federation of Public Health Associations, our attempt is to reach out to our member organisations in order to encourage them to influence government. And part of the role I play is also teaching them the advocacy techniques. And of course, we can talk about the advocacy techniques, but in the end, it takes that effort to knock on a door, to write an email, to encourage others to be involved. But the World Federation of Public Health Associations deliberately put out that charter for the public's health in order to explain those fundamentals of protection, prevention and health promotion, and then the enablers that make them work. And part of that is coordinating, of course, with the World Health Organization and coordinating with other organizations, certainly in Geneva, but also around the world.
Thank you very much. Jane?
Yeah, thanks, Justin. It's a great question. First and foremost, the IFAA has formal relations with the WHO and the United Nations, and our priorities are very much aligned with those two authorities. More particularly, the 4 action areas I talked about with the decade, ageism, long-term care, primary integrated care, and age-friendly. At the heart of our work and the way that we work is bringing unlike together. I've been in this business for a long time, and so, talking to, a room full of geriatricians or experts in ageing is not taking us anywhere. So when we talk about bringing unlike together, in our expert meetings to develop a common agenda around adult vaccination, we bring together diabetologists, heart specialists, patient groups representing those constituents, etc. Because by bringing them together, we actually know what we know, but we know what we don't know. And so we found that working in this way, we actually develop a common agenda, at a national level, because our job at IFA is to help build the capacity of others at a country level, because they're on the ground. They know the policy, they know the relationships, they know who pulls the strings. And so that's our job. I think over the last 10 years now, adult vaccinations has been one of our strongest priorities, and it's because it's winnable. It will make the biggest impact in the lives of older people who, unfortunately, succumb to, vaccine preventable diseases. So it is winnable and it is a priority. Just earlier this year, we launched the Vaccines for Life knowledge portal with lots of resources. But I think another effective way we work with others, and I think the important thing is we never work alone. It's a waste of time because the world is connected in such a unique way. We build on others, we stand on the shoulders of others, and we hold other people up, to the common good in this particular field, vaccination. Consensus statements that we come together with, pledges, for greater investment. So our part in this whole global conversation is to build the capacity of others, to inform WHO and UN in a way that member states hear the voices of those who are most vulnerable. So it's very much, collective collaboration, moving forward in one direction together. Thanks, Justin.
Thank you very much. And David?
Great, thanks. And, very similar and again, very to my colleagues now, I think it's worth us flagging, like Jane said, that actually we are working together. There is a big world out there and a lot to do, and actually us, I think, within this coalition and broader, it's extraordinarily important that we do work together as organisations. ILC UK, just to expand a little bit, we were set up in 1997, and we look at the impact of longevity on society. We're not an older people's organisation, so we're as interested in how we get young and support younger people to age well, to save into a pension, to think about social care, as we are about thinking about today's sort of generation of older people. So we're fundamentally interested in how we can adapt public policy because we have more and more older people. We, like Jane, like the like yourself, Justin, we do lots of research into this area across, I suppose, three areas. One is the longevity dividend. So how do we make the positive case for aging and for the case for investing in and recognizing that older people are, actually are contributing significantly. So that's one priority. Secondly, a sort of priority around diversity and recognizing that, we have a very diverse population, and this is where things like democratizing access is extremely important. We have to tackle health inequalities. And then thirdly, I think we work around with a focus on ensuring that public policy works for all generations. What we try to do, as well as doing research like Jane, is catalyze conversations. We run sort of 30 to 60 events with policymakers across the world, with policymakers and decision makers and advocates, and are really trying to reach as broad an audience as we possibly can. And actually, I would say that there is need for more of us working together in this space. The world is big and there aren't many of us. So I would encourage everyone on the line to get on board and try and support this agenda even more, whether that be supporting consensus statements that people like Jane or we do, or helping disseminate the findings of research, because there is a lot we need to do together.
Thank you very much. I enjoy hearing about the work that your organizations do. The next question, maybe the next couple questions, have to do with the obvious need for building and strengthening adult immunization right now, given the global context. We are experiencing the worst public health event in over 100 years, and unlike the 1918 pandemic influenza, which disproportionately affected young adults, the current COVID-19 pandemic is disproportionately affecting older adults. David, in his discussion earlier, mentioned just how many countries are not meeting the World Health Assembly goals of immunizing more than 75% of adults with influenza vaccines. And it has been referenced previously that adult immunization programs aren't as strong as pediatric and have not received much global attention. Now we're looking at the potential for COVID-19 vaccines to be licensed and rolled out. Hopefully there will be many vaccines that will be developed and licensed and made available to everybody who needs them. But how can we do that? How can we reach all the adults with chronic disease and older adults, given the limitations of immunization services that David Sinclair mentioned? And how can we effectively advocate for resources and focus from our local and national governments, as well as from a global perspective? And I'll kindly ask that the speakers again answer the question in the order that they presented. Thank you.
In that case, I think I get the opportunity to start. Look, it's very interesting. I think the most important thing to understand is that in the context of this pandemic, what we have is a situation where you're going to be even more vulnerable if you're also suffering influenza. It is interesting in my own country, in Australia, where early action was taken to prevent COVID-19, and the success has been pretty remarkable. But the even more interesting part is we've had very, very low cases of influenza. And so in some ways it's been quite a challenge for public health bodies, whether it's the medical associations or nurses or colleges of medical practitioners. What's really happening is that we have still maintained quite a high influenza vaccination, but I wonder if that success is going to then be seen as, oh, look, actually flu's not so bad. And this is the paradox I talked about before, the prevention paradox. The more successful we are, the less we're noticed. And I think that really provides challenges. But in the end, the influence on government comes from the medical associations, from the nursing associations, from the health promotion, from the epidemiologists, from the public health associations. I do, just as an aside, laugh because it seems that everybody actually now knows the word epidemiology and actually have finally heard of the work that epidemiologists do. But look, in the end, I think that's the best way I can answer that question. Over to you, Jane.
The environment in which, sorry.
Yep, no, you're away.
Yeah, okay. First and foremost, let's start with the environment in which we're living in and the messages that older people and those with chronic conditions are actually receiving. You know, you're locked down, you know, you're cocooning, so stay inside, don't go out, it's a frightening place, these are the things that you need to do. So, you know, that's one set of messages. I think the other set of messages is, you know, it's influenza season, other respiratory conditions, go and get your flu vaccine. So public health needs to be very clear about the safe pathway to be vaccinated. So I think that there's work that needs to be done there. I think also we're in a new place. There are new conversations with different relationships going on. You know, I'm now on WHO calls where Department of Ageing and Health are on the same call as the Department of Vaccines. Now, you would know, Justin, that that's pretty rare. And so we are seeing that through this unprecedented global situation, that there are conversations across sectors and across disciplines. So that's very promising. It's way out of this scope and also my pay rate to be talking and thinking about efficacy of COVID vaccines for older people. And only the best of the best are thinking and working on that. But that's a real issue for our population. I think the other issue that we haven't mentioned is that older people are not worthy of this new vaccine. And we've had many examples of politicians and others saying, well, you know, they haven't got too long to go anyway before they die. So, no, you know, if they don't get seen at the emergency, well, you know, and I can say one of our former Australian politicians, what is the cost that we're going to pay? How many people are we going to allow to die, even if they're older people? So that's another part of the conversation. The good news is we've had Dr. Tedros, you know, Secretary General from the UN coming out and saying older people are part of our community. And if we're lucky, we will get to a ripe old age and be healthy. Thanks, Justin.
Great. And I think two main points for me. I think firstly, in terms of the, you know, that how, I think we've got to learn a bit from what works and for example, you know, how have, you know, Taiwan and Vietnam, for example, very successfully managed our pandemic in a way that countries like the UK have not. You know, learning from what works, I think, is extraordinarily important. Similarly, I think, you know, in terms of vaccine-preventable diseases and in terms of adult vaccination, I think actually we need to make sure that we are sharing why places like Australia, South Korea, UK manage to get higher rates of adult vaccination than other places. And, you know, it's very clear that, you know, in the UK, for example, you know, astonishing use of real-time data and management from Department of Health down to local GP surgeries has actually played a big part in it. So learning from what works, and I think if we can do that, that's really important. In terms of advocacy, I think what we've got to do, and we have an opportunity next week, and again, I would encourage everyone to think about this. Our finance ministers, the G20 finance ministers are coming together next week. I think we've got to, and Jane talked about not usual suspects, how do we get different people? I think we've got to engage finance ministers to recognise the economic costs of failing to prevent. So yes, this is vitally important that health ministers get it, but I think they do. It's about people, it's about the finance ministers putting their hands in their pockets as well. So let's be talking to them as well.
Much. I appreciate your comments. And we are receiving some questions in the Q&A. Looking at the time, I'm hopeful that we'll be able to answer all of them. So please, if you have questions, ask them in the Q&A function, and we will get to them. Next question I have, and I don't want to put all three of you on the hot seat, but you're welcome to respond if you like, is in the context of this COVID-19, or in your experience with other policy making, what have been some of the effective ways you've seen vaccine preventable diseases made into a priority? And we've talked about health economic perspectives, the health impact perspectives. We would appreciate your thoughts on effective ways to make vaccine preventable diseases a priority.
I think, David, I think I'd say that actually, compared to where we were 18 months ago, I think vaccine preventable diseases are a much, much greater priority than they were. I think in fact, this time last year, we published a piece of work looking at the 100th anniversary of the Spanish flu, and we were talking about the fact that another pandemic was likely, that we needed to focus on hand washing, that we weren't concentrating enough on vaccine preventable diseases, that there's all sorts of reasons why the risk of vaccine preventable diseases was increasing, and of course we weren't the first people to say it, but the epidemiologists, the health economists, Bill Gates sort of 4 or 5 years ago in his big speech talked about it. The reality is we've been aware for a long time that we've been really complacent about this agenda, and I think one thing that the pandemic has done has meant that all of a sudden policymakers can't be as complacent. So, and I think that, offers, the challenge now is for infrastructure. So how can, particularly if, older people are most at risk and we want to get this, a vaccine to older people, how can we make sure that we deliver the infrastructure when 10 years on, we're failing in most countries to deliver flu vaccine to the numbers of people we want. So governments have got a massive job to build this infrastructure, and they're going to have to learn from places like the UK very quickly.
I learned a couple of lessons from other areas. The HPV vaccine, I think, is a really good example. We're talking about adult vaccination, and yes, that starts with children, but interestingly enough, the pressure has come in our country, which is highly vaccinated with HPV now, is in women's groups. And it goes back to Jane saying, don't just always go to the usual suspects. And I think that is a really important part of what we do. And there's an interesting balance between when things go right and things go wrong. And one of the, when things do go wrong, such as the measles outbreak in Samoa, it does highlight to the general community about vaccination generally, and then taking it and moving that towards adult vaccination and vaccination of the elderly becomes a thing forward.
I think also, though, we've got to just be real about the population that we're talking about. Children versus older people, when we're actually living in times of austerity, is actually going to be very critical. So yes, there is a business case to be made, and we don't do well, and we shouldn't pat ourselves on the back. You know, we don't do well in actually building the business case that older people who are functioning independently at home is less cost to the community. Actually, they contribute to the community versus someone who has been hospitalised with a respiratory infection, which is vaccine preventable, and now is in a nursing home. So that's the kind of business case. I think also we've actually got to remember and call on different professionals to expand the gateways. So pharmacists, you know, a perfect gateway for older people and those with chronic conditions to be vaccinated. But pharmacists in every country cannot vaccinate. So let's join with FIT in advocating for that. The last point, Justin, and you know, I bring it up constantly, and that is the composition of NITAGs, you know, National Immunisation Technical Groups. Now, IFAA is in the middle of an analysis, and it's concerning that the composition of NITAGs in many countries, you know, in one country, 4 paediatricians out of 10, and no person with qualifications in the field of adult vaccination or gerontology, geriatrics. So we need to actually be looking at a multi-pronged approach when it comes to, you know, looking at barriers, but also creating solutions for the politicians. Don't go with a problem without a solution, because they like to have both, because they want to win as well.
Thank you all for your thoughts. I wanted to share a few as well regarding this question. In some ways, it is easier to measure certain health outcomes or economic outcomes than it is to measure strengthened health systems, right? It is, but it is absolutely true that building programs to immunize adults will strengthen not only public health delivery platforms, delivery of preventive medicine services, but can also strengthen pandemic response. Colleagues from WHO recently did an analysis of countries that received donations for influenza vaccines during the 2009 influenza pandemic, and they found something which I don't think surprises any of us, but it's nice to have documented, that countries that had existing influenza vaccination programs were able to respond more quickly and more ably to influenza vaccine pandemic response. Yeah, and the reasons for this are multifactorial, but they include regulatory experience with influenza vaccines, systems in place to deliver vaccines to older adults, the knowledge around safety and safety surveillance for these vaccines, et cetera. We have a need, just from a pandemic planning perspective, you know, at least a future pandemic planning perspective, it's a little too late now, to strengthen the influenza vaccine programs in the event of a future influenza pandemic. With regards to the current COVID response, we are also going to benefit from the existing systems that are in place and the planning that has been done. If you think about other approaches to immunizing older adults, strengthening healthcare worker immunization is certainly another public health need and can be achieved with adult immunization. Strengthening antenatal care, just in general, can occur concurrent to strengthening of maternal immunization. So we're I think that a rising tide lifts all boats, but sometimes it's really hard to measure these broader public health benefits in a vaccine preventable diseases context. So let me move on. We still have opportunity to ask more questions, so please feel free to enter them into the Q&A function in WebEx. Another question from the attendees is, can you think of any examples where there has been let's say, a trickle down from global recommendations to country-level policy change? And an example is given by the questioner, for example, WHO recommendations that have encouraged a country to introduce new vaccines or something similar. So may I ask, in your experience, perhaps not just with immunization, but with WHO policy in general, have you seen an impact at country or other levels?
Justin, I'll kick this off, and I put it in the frame of reference of frameworks, plans, strategies, versus WHO policy. And I can say that back in 2007, WHO developed the age-friendly cities and communities, right? And across the course of now more than a decade, there are thousands and thousands of cities and communities that say they're age-friendly. There's over 1,000 in the global network of age-friendly cities and communities. And what that does is it is at a very local government level, so that local governments are then, looking at their policies and practices around older people so that there is an environment that they can maintain their independence and contribution. This umbrella of age friendliness is also a really interesting umbrella to improve adult vaccination rate. See if we can actually work with the cities and communities. So I think that that's a really important contribution and response to the trickle-down effect, which is around the world.
Perhaps I could add something there, because I think it doesn't just come down from the WHO. Often things are almost circular. So I'd like to use the example of the Framework Convention on Tobacco Control, which I think has had a major impact internationally, and certainly in my own country has had a significant impact. But it didn't just come down from the WHO and trickle down. It's countries working together at the World Health Assembly to try and make sure we have that kind of outcome. And I think you'd find the same with the transition from the Millennium Development Goals to the Sustainable Development Goals. It's both up and down, and so I think that it's not quite so straightforward, but they're likely to be much more effective when the country's been involved in helping develop the WHO policy in the first place.
I've got anything to add other than, I think it is extraordinarily important to look both ways, to make sure that where there is some really good practice going on in countries, that this gets observated by the WHO and then comes back down to others who need that support.
Thank you all very much. And I think the one global policy, I guess not the only one, but one of the global policies we discussed in the last hour was not particularly successful. This is the World Health Assembly resolution that older adults receive 75% influenza vaccine coverage. That said, the WHO and World Health Assembly policies and mandates have a tremendous impact, notwithstanding that one example, tremendous impact on policy making, particularly in low middle income country settings. And so while often the UK or the US or Canada may not fall in step after WHO makes a vaccine policy recommendation, many countries globally do rely on the recommendations, expertise made by WHO SAGE, as well as regional immunization technical advisory groups, and we can think of many examples. You know, the introduction of new underutilized vaccines, the close coordination between WHO and Gavi with regards to the funding and implementation of new vaccine programs. So having WHO on your side, having WHO advocating your cause is very critical, and something that WHO has learned, and I think that this webinar is an example of that, is that you absolutely must have people from many different backgrounds, many different places working together to try to solve common problems, often with different perspectives and approaches, and that is certainly being undertaken now with COVID-19 response and with the strengthening of adult immunization globally. So I think that we are living a great example of how we could make meaningful change and moving policy into global health action. There is one final question I want to ask before we summarize and wrap up at the top of the hour. This was asked by one of the attendees. When many older adults have undiagnosed underlying chronic conditions and a lack of access to care, what can we do to reach the most vulnerable when they have been left behind or lack trust in the system?
Oh. Yeah, go on, David.
I think for me the number one is we need to make vaccination as accessible as possible and go to where people are. So actually not expect someone to be traveling 10, 20, 30 miles or whatever it is to get your preventative treatment. I think we've got to go to where people are and deliver it as close as possible, whether that be using pharmacy, whether that be using other community settings, but we've got to go to people and not expect them to come. I think that, a final sort of linked comment is, of course, over the last sort of 50, 60, 70 years, we've massively increased life expectancy, partly by reducing average mortality in younger people. Actually, in terms of adult vaccination, we're only at the beginning of a journey. It's 20 years since we had age-related, sort of an older adults recommendation in the UK. And compared to our long history with pediatric vaccines, we're still relatively new. In the last sort of, we are seeing huge innovations in vaccinations. And undoubtedly what we see now, we are going to see as a result of the pandemic is a much greater focus on policymakers in this space. And I think that actually we need to make the most of that opportunity to ensure that everyone, including those who are at risk, are getting the treatments they deserve. So I think that there is an opportunity now.
Thank you very much. I will end the Q&A session for the webinar. There are a few things I wanted to say. First, I want to thank very much our expert panelists who have taught me a lot, and we're very lucky to have such expertise available for the Immunization for All Ages group, as well as for this webinar. For the attendees, I want to alert you to the fact that this webinar is only one of a series of webinars. Today we discussed driving policy to action, but on November 12th, we will have another webinar that will discuss advocating for the life course immunization. And on December 8th, we have the third of our series would be focused on defeating meningitis. To sum up our discussion today, public health leadership is needed to drive vaccination throughout life and must go beyond the traditional model. Stakeholders and truly seek commitment of local leaders, professional associations, patient aging organizations that understand their constituents and the inherent value of a common agenda that is accessible to individuals of all ages, particularly the most vulnerable among us. I want to thank my colleagues in the Immunization for All Ages group. We would like to thank our funder, Pfizer, who provided the resources for this to happen. And most importantly, I would like to thank all of the attendees. We really appreciate your interest in our work and what we have to say, and we hope that you could help to propagate our findings and our discussion within your own communities so that we could build a movement to strengthen adult immunization globally.